Hi, I'm Harriet. I'm one of the reggers at Charing Cross, and today I'm going to be talking about this paper, so the anti-CD3 antibody teplizumab in relatives at risk for type 1 diabetes. It was a study that was published in the New England Journal of Medicine in August 2019. So as we know, it's happy birthday insulin in about a month's time. So it's 100 years since the first human was treated with animal insulin. But type 1 diabetes is an autoimmune condition. And so what developments have we had and what discoveries have we had in the realm of immunotherapy? Well, you can see at the bottom of that timeline, it's slightly less busy than the metabolic side. We can see in the 1980s that cyclosporin did show efficacy in reversing new onset diabetes, but was highly toxic. And then in the mid-90s, we had teplizumab that was developed essentially or originally for patients with renal transplants. And that's a CD3 monoclonal antibody. And then subsequent to that, in 2019, on the back of the study that we're going to discuss today, the FDA designated teplizumab breakthrough therapy for the treatment of patients who were deemed to be at high risk of type 1 diabetes. So just taking a step back and thinking a little bit about immunotherapy for type 1 diabetes, there are a couple of questions and concepts which we need to consider. So who should we treat? So who has type 1 diabetes and how do we identify them? When should we treat them? So essentially at what stage of their disease trajectory? And which treatment should we use? And I think that's important to think about because diabetes is an autoimmune disease. We have a safe treatment, although it's not perfect, but we do have insulin. And that slightly differs from other autoimmune diseases. So this is a consensus statement that was published in 2015, really, that aimed to stratify those diabetics into symptomatic and pre-symptomatic. And they propose essentially 3 stages. So the first stage is evidence of autoimmunity with 2 or more antibodies, normoglycemia, classed as a pre-symptomatic stage, moving to stage 2 with evidence again of 2 or more antibodies, dysglycemia, and then eventually into symptomatic type 1 diabetes. So essentially, we know that stage 2, so these are patients who have 2 or more antibodies and have a relative who have type 1 diabetes, are at risk of progression to type 1 diabetes. And we know that from a number of large cohort birth studies. But actually, we know that after 15 years of follow-up, approximately 1 in 6 of these patients will not develop type 1 diabetes. So again, just looking at that stage 2, a 2-hour OGTT glucose level will best predict progression to diabetes, as seen in the diabetes prevention trial in type 1 diabetes, but actually the level doesn't really begin to change until about 0.8 years before diagnosis and then rises rapidly. Other metabolic parameters were not predictive of progression. And again, as we know, a decrease in stimulated C-peptide will lag behind any changes in the OGTT, and fasting C-peptide levels are generally maintained in the normal range in that stage 2. So this is just a bit of an overview of what immune therapies have been trialed in diabetes. The ones in red are treatments that have been trialed and have been deemed to have failed. Those in green are treatments which have had some success, and those in red are undergoing investigation. I should mention that HSCT is hematopoietic stem cell transplant. And we can see that the vast majority of immune therapies have been trialed really in stage 3, so those with a diagnosis of type 1 diabetes. And very few have been trialed in this stage 2, so patients at risk. But one of them that has shown some success is teplizumab. Yes, especially when we know, that the cohort data shows that sort of 1 in 6 after 15 years still don't have diabetes. Yeah. So essentially, teplizumab is a monoclonal antibody which selectively blocks the CD3 receptor. As I say, it was developed in the 1980s. It showed in preclinical studies in non-obese diabetic mice during the 1990s that a short course could induce long-term remission of autoimmune diabetes, and that sort of created the foundation for translation into human studies. So it essentially, as I say, it acts at the CD3 receptor. It causes partial depletion of autoreactive T cells, will cause CD8 positive T cell exhaustion, leading to an immune tolerant state. So in 2011, teplizumab was trialed in patients who'd had a known diagnosis of diabetes. So they'd been diagnosed less than 12 weeks ago. And that was with the idea of looking at whether there was any evidence of disease reversal or reduced insulin use. But it didn't, that study didn't meet its primary endpoint of diabetes reversal or insulin reduced to less than 0.5 units per kilogram per day. So the idea was that actually we'd try and look at teplizumab rather than in those stage 3 patients who've got diabetes. We'd actually take a step back and look at those patients who are at risk. So this was a phase 2 randomized placebo-controlled double-blind trial involving relatives of patients with type 1 diabetes who do not have diabetes but were at high risk for development. So and they class that as, again, those patients with 2 or more antibodies. So it really had one primary endpoint, and that was the elapsed time from randomization to the clinical diagnosis of diabetes. And the study was powered to detect a 60% lower risk in the teplizumab group. So the participants were identified through the TrialNet natural history study. So that was a network of 19 clinical centres worldwide that conducts research on the study, prevention and early treatment of type 1 diabetes. So as I mentioned, these were non-diabetic relatives with 2 or more diabetes-related autoantibodies detected in 2 samples obtained within 6 months before randomization, with evidence of dysglycemia, as I've noted there. So essentially, you can see here that in total, 112 participants were screened, 76 were randomized, and then we had 32 that were assigned to receive placebo and 44 were assigned to receive teplizumab. And of that 44 patients who received teplizumab, we had 1 loss to follow-up, and again, the same for placebo. So just looking at the baseline characteristics, we can see that all participants were positive for at least 1 antibody, 71 were positive for 3 or more antibodies, and the majority of the total participants were children, but the age range was 8 to 49 with a median age of 13. They mentioned the HbA1c of these patients. It wasn't particularly different between the 2 groups, but actually they don't really ever refer to the HbA1c again. We can see that the BMI is essentially normal in all groups. More than half are actually siblings of an affected person with type 1 diabetes. And you can see there, there is a range between the teplizumab and placebo group of patients who've had number of autoantibodies positive. We know there is an additive effect in terms of your risk of type 1 diabetes when it comes to the number of antibodies that you have. And they don't really offer, they tell us the antibody titer and give us the median, but they don't really tell us at what cutoff they were using for antibody positivity. So this was a double-blinded study with a 14-day outpatient course of IV teplizumab or IV saline with doses of teplizumab seen on the screen, and this was following essentially a protocol that was used by the previous study in stage 3 or diabetic patients. And these patients had scheduled oral glucose tolerance tests performed at 3 months, 6 months, and then 6 months thereafter, to a total of 60 months. They had random screening glucose levels, which were evaluated at 3-month intervals, and an oral glucose tolerance test performed if a random glucose was 11.1 or above. And patients' blood was also sent for flow cytometry to look at T-cell phenotyping at 3, 6, and 18 months. So essentially, this is a Kaplan-Meier estimate of the proportion of patients in whom clinical diabetes was not diagnosed. So the overall hazard ratio was 0.41, and that did reach significance. The median time to diagnosis of type 1 diabetes was 48 months in the teplizumab versus 24.4 months in the placebo group. And you can see that the number of participants with or without a diagnosis of clinical type 1 diabetes represent data at the conclusion of the trial. So although it did reach significance, we can see that essentially the proportion of type 1 diabetics does decrease over time. You can see that again happening in the teplizumab group. Yes. And essentially the paper goes on to describe that the annualized rates of diagnosis of type 1 diabetes were 15% per year in the teplizumab group and 36% in the placebo group. And the percentages of participants with progression to type 1 diabetes in the overall trial population. So we can see here from the supplementary appendix, essentially the number of type 1s who were diagnosed in both groups per year. And I think it's quite striking that essentially in the placebo group, we do see that high percentage in the first year, which they essentially conclude that they sort of conclude from that these patients are really high risk, and you can see they will develop type 1 diabetes in that first year. And then just looking at a subgroup analysis, we can see really that there was only, the presence essentially of anti-zinc transporter antibodies seemed to, in the teplizumab, it seemed to give you a better chance of not having diabetes given the teplizumab. Does that make sense to everyone? Or sorry, those with the anti-zinc transporter antibodies without the I'll start again. Those without anti-zinc transporter antibodies generally did better, had less diabetes with the teplizumab. So this was looking at the average stimulated, where is it? Here. So what they did was they took the stimulated C-peptide area under the curve. So they haven't actually said what they're.
Sorry, we can't hear the questions that you're being asked, Harriet. Could you move the microphone so that we can hear the questions?
No, I was just asking about, you see that C-peptide level? It says median less than 30 or more than.
I think that's just the number of.
So low, what was that?
No, so what they've done is they've looked, so on a mixed meal test, they measure the C-peptide. This is standard protocol at sort of 60, 90, 120 minutes. Right. They calculate the area under the curve and then they take the median. So what they've done.
Median? Oh, I see.
So if you're below the median, then your area under the curve is below the median point.
Okay. So they do well with, okay, so if you've got a low C-peptide,
area under the curve, below the median. Yeah.
Yeah, I got it. Thank you.
But obviously, I suppose within that, you know, the C-peptide, we can see that the confidence intervals are overlapping, and there's quite a, you know, those intervals are quite wide. So this is the effects of teplizumab in treatment in participants whose C-peptide area under the curve was above or below the median. So I think above, A is above and B is below. And yeah, we generally found that those who had responses below the median were associated with a better response to teplizumab, which I think is essentially, you know, I suppose gives some weight to the theory that teplizumab works best in patients who don't have fulminant beta cell death and do have some preservation of C-peptide. But again, there's quite wide confidence intervals that overlap. And essentially, they then, with flow cytometry, looked at the frequency of a certain subset of CD8 positive T cells, and this subset of T cells has been shown to be increased in patients with a response to teplizumab in previous studies. And we can see that the frequency as a percentage of the total CD3 expression T cells in the teplizumab group was higher. No, although they don't actually say whether it was or wasn't significant. In terms of safety, so the majority of the grade 3 events in the teplizumab group involved lymphopenia during the first 30 days. It did resolve by day 45 in all participants except one, and that did eventually return to normal after just over 3 months. There was a spontaneously resolving rash, which is a known effect of teplizumab, that occurred in participants who received it. And we know that there was some seroconversion of patients known to have antibodies against EBV. So we had a number of patients who had quantifiable EBV DNA, and they were all in the teplizumab. Some of them had symptoms of EBV viremia, but actually they did seem to clear their EBV DNA anywhere between the day 43 and 134. So just thinking about the limitations, this is quite a small cohort study. The authors of the study really had trouble trying to recruit to this study. We don't have that much information about the overall glycemic control at baseline or throughout the study. And actually, we don't know about the C-peptide trajectory. So really, we just have that baseline stimulated C-peptide. We haven't tracked their patients' antibodies, which I think might help give us a bit more information on who exactly is at risk from this group. And finally, we don't know if any of these patients had antibodies to teplizumab. So just thinking more generally about immunotherapy and teplizumab, this study essentially did show a 26-month delay to diagnosis. What does this really mean for real-world outcomes? Does it really mean less exposure to hyperglycemia? Does it mean less rates of DKA? How would you perhaps sell this to a patient who you thought was going to develop type 1 diabetes? And as I say, about 1/6 of this group will not develop diabetes. So who exactly are we trying to treat with immunotherapy, and how safe is this treatment? So I think that just brings us back really to those initial questions about exactly who we should be treating with immunotherapy for diabetes, when should we treat, and which treatment.
That was really clear. I think I'll sit here so that you can you hear me from here? I think the direction on that mic. Oh, good, Rick Batty somewhere. That's quite good. Okay. Any thoughts, Giovanni? Or any other type 1 experts?
Thanks, Corinne. Thanks, Harriet. I do have one thought, because I haven't actually read this paper, but was I right in hearing that you said they selected people that already had evidence of dysglycemia?
Yes.
And also had a family history.
That's
Yes.
fine, because stage 2 is a family history plus 2 antibodies, right? But that is very different to a family history plus 2 antibodies plus evidence of dysglycemia. So your conclusion about 1 in 6 people would never go on to develop type 1 is the case for people without dysglycemia. So these people are probably more advanced in stage 2, and all it's done is delayed the presentation. I say that in a sort of dismissive way. That's, if you talk to people living with type 1, that might be quite an impactful thing, especially in a child. But yeah, my major comment is how it was powered, because it looks to me, you showed that forest plot and the confidence intervals were all really quite wide. So what did they power their small study on? Was it C-peptide change?
You had it on the slide. They assumed 60% would remit, yeah?
But I don't know how they did that, essentially.
60%. They assumed that, Shivani, I guess.
Yeah, I mean, I think it's quite small. The type 1 patient groups were all over this and really excited, and it is sort of exciting. But the question, there's 2 issues. One is, how do we identify those people that would meet the criterion? And there's a big push from patient groups and other researchers to actually introduce antibody testing as a screening program, which has received quite a lot of opposition, mainly because there isn't anything that would actually, an intervention that would actually, completely stave off type 1 diabetes in that scenario. And then the question is, what are the gains really of delaying the diagnosis by a few months?
2 years. 2 years?
Yeah, let's just say 2 years.
It's more than a few.
No, I know, but I mean, it's not, I'm not dismissing it, but it's not huge, is it? No,
agreed. Especially into the side effects, like EBV and stuff worried me with it. If you're going to immunosuppress someone and they get stuck in the infections. Yeah, and if someone gets sepsis and dies, that would be the end of it, really, wouldn't it? That's the only danger.
Sorry, could I just ask, how long would you have to continue the immunotherapy for? Is this lifelong or?
Until you get diabetes. And then it's no point. If you just go forward to the slide with the graph on it.
I thought they gave it for 14 weeks.
So it was actually 14 days.
Oh, is that all? Oh,
yes, it was just 1 dose.
Oh, I see. Okay.
But it is unclear whether you'd need further doses as the years go by. It is unclear if this is a one-shot deal.
Yeah.
Because of course this is for life. Sorry, I'm joining a bit late. I'm sure you've had some discussion, but it's for life, isn't it? And Shivani's point is the crucial bit here, isn't it? Is this clinically and cost effective in reducing, in the staving off 16 months, what is essentially a 5-decade disease? Does 16 months give you enough clinical or cost effectiveness for retinopathy after 30 years? And it's very difficult to know.
The other question is on this graph. So I mean, once you've got diabetes, there's no point having another dose. So supposing at 24 months, you've lost 25% of the patients already in the TEP group, you give them another dose. I wonder if that will help. Just a question, really. Because once you've got diabetes, then it's all, from this point of view, you've lost it, haven't you?
Yeah, absolutely. And they separate early, those graphs, and actually once they're separated, the slope is roughly the same, isn't it? So it separates in the first 3 to 6 months, and then the rate of decline is about the same. What is interesting, what would be interesting to know, is whether those DR4 negative zinc transporter positive signals that suggested response or associated with response would be the same at 24 months, or whether those people have had their type 1 diabetes prevented already by one dose. And again, we don't know the answers to this.
The thing that makes me think it's not powered very well is that drop in the, you see that drop in the placebo group within the first 6 months, which pretty much accounts for the difference really, because you sort of see that drop between 18 and 24 months in the teplizumab group. And it just makes me wonder whether that's artificial and just down to relatively small numbers, because the biggest drop there is in the first 6 months, which just doesn't seem.
Yeah, the other possibility though, your first point about the selection, they select people who are just on the edge of becoming diabetic.
Yes. Those HbA1cs were, you know, okay, in the normal range, but not what you would expect for a completely healthy child, right?
There's adults in there too. The weird thing about the HbA1cs is that they're discordant with the dysglycemia. So they selected people who had 2 or more antibodies and evidence of dysglycemia, but their HbA1cs were not in the impaired glycemia range, which is a little bit weird.
Is it though? I saw that. Is it? I explained that in my brain by the fact that they've only just developed dysglycemia and they've not glycated enough, which is why HbA1c shouldn't be used for diagnosis of type 1.
Yeah, that's a good point. Don't know. Yeah, absolutely. TrialNet should have previous values for those participants, but obviously we can't see them. But the flow cytometry and the other data from Protégé go along with the 3 to 6 month response to teplizumab, don't they? Is that right, Harriet?
Yes.
So I think that initial drop that you see that drives the difference throughout the rest of the study, I think that probably is genuine, despite the numbers.
And then what do you think then about giving a second dose to the blue group at 18 months when you've got 90% still non-diabetic?
Yeah, it'd be good, wouldn't it? Who knows? But then again, who knows how much more EBV you might get, or whether EBV reinfection and later lymphoma rates go up. I mean, the thing I always think is, would I give this to either of my children if they develop type 1 diabetes? And the answer is no, not at the moment.
Agreed. But you might if you had 2 other children with type 1 diabetes and
I would never have 4 children, Kareem.
It's Emma here. Just a quick one. You'd want to do it on the group that haven't got any evidence of diabetes, really, wouldn't you? Like the not having dysglycemia, to try and stop it altogether.
Yeah,
there are studies looking at earlier stages. So Harriet, I think, showed that slide earlier of the JDRF consensus stages of pre-type 1 diabetes, and there are people looking at studies in stage 1. The problem is that you have to power it, you need a lot more people, because obviously more people will regress to normal glucose tolerance and not develop type 1 diabetes in the period of time that they're being studied. So they become harder, more expensive, longer, bigger studies. And this is the lower hanging fruit to do it at stage 2. So the first studies were in stage 3 or new onset type 1, and then they're sort of working their way slowly backwards and adding data to the increasing clamour for a type 1 screening program that has lots of problems associated with it, not least of which it doesn't meet any of the criteria for an effective screening program. Not even for preventing DKA. So it's super interesting, and there's an awful lot of discussion in the type 1 world about what we do with some of this.
Very good.
Thank you. And how does this drug manifest in its uses elsewhere? That was my other thought. Can we learn anything from that about side effects and intervals?
Is it used for anything? It's only for this, Emma. It's not in use for anything.
No.
Oh, okay. Even more reason to be cautious. Thank you.
It's designed specifically for type 1 diabetes prevention. Targeting that protein you mentioned at the start.
Mm-hmm.
So just to add to Nick's comments, what research is focusing on now is trying to identify the sort of endotypes of people at risk of type 1 that would benefit more, because there's likely to be a lot of heterogeneity in this group, even though it's defined by antibody status. So they've got sort of Mendelian randomization, essentially according to LHA, HLA, haplotype, numbers of antibodies, family history, and they're really trying to suss out who the ones are that would respond more.
Thank you all. Thank you, Shivani and Nick.